I don't have much to add beyond what's in the paper. So if anyone's read the paper, this will be a little redundant, but the discussion part is what I'm really hoping to get into, and ideas for future work, and with a group of people like this who do this every day, you know. So your insights are what I'm sort of here for. So, you know, the context is for this group that knows this well, you know, community-based management of acute malnutrition or wasting, the terminology keeps moving around, right? It's been endorsed for children under 5 years old. It's a functional model that works okay. You know, it has its flaws, it has its means that we need to improve it, and better, you know, unified, simplified approaches, and better coverage, and newer foods, and many other things can be improved that many people in this group are working on. But it sort of, you know, exists and it's out there. And, you know, for example, in 2019, 11 million children did receive treatment for this. But there's, you know, at least 2/3 of the children in the world who are wasted do not receive treatment. So this is the context that this idea comes from. And, you know, the work from the MAMI working group and many collaborators along the way has recognized that severe wasting in infants under 6 months is not covered by these sort of guidelines, and is among the, you know, if we consider wasting to be a neglected disease, this is another wasted, even more neglected disease within that neglected disease. You know, there's a paper that Marco put out more than 10 years ago that had 8.5 million wasted infants under 6 months. I haven't seen lots of data since then, but as a floor, we have at least that many children, infants, who are wasted. And of course, they have higher morbidity and mortality rates, and the consequences of their wasting, the earlier it happens, is probably linked to even more cognitive and developmental stunting. So it's a really high priority group, you know, of course, for making sure that their wasting is addressed well. The MAMI care pathway that many of you were involved in, you know, this is the new version of this, has a lot of great ideas for helping identify, support these infants, their mothers, and to help manage them and prevent relapses and things like that, and continue to support the mothers even after the infants are no longer wasted, and really moving from the emphasis away from treat and medicalize this to a more holistic support model. Coming at this as a very much of a simple physician and saying this broke and be fixed, rather than the whole context that is the more important context. It always struck me that there's no great specific treatment for wasting in these infants in terms of like a medical intervention. You know, this bone is broken, I put a cast on. This, you have this infection, I give you this antibiotic. Sort of the simple thing rather than the whole context. It seems like it's lacking. You know, the inpatient care for children who are wasted, you know, it's very similar in some ways to children older than 6 months. You know, you achieve clinical stabilization, dealing with hypoglycemia and hypothermia and sepsis and things like that, admit them to the hospital, provide them with a therapeutic milk, which may just be breast milk, you know, encouraging better breastfeeding and supplementary suckling and these things, or fortified infant formulas, or, you know, F75, dilute F100, these sort of things in an inpatient setting. The outpatient setting focuses on counseling and addressing risk factors for the mother and mental health support and all sorts of very important things that don't, as far as I can tell, specifically include a food product or a nutritional supplement per se to the infant. And ideally, the counseling and support for the mother and improved breastfeeding and these sort of things would be enough to help the infant recover from an acute episode of wasting. So this is, you know, again, I'm focusing on the child who's already wasted, not the more important, broader picture, or the broader population of children at risk. And so what happens is that these babies are seen in therapeutic feeding clinics and CMAM clinics and told, you know, given a lot of counseling and breastfeeding support and maternal support and maybe some medical support for the child and immunizations and things, or they're told to go to the inpatient setting and get admitted for a long time and get an NG tube, get supplementary suckling, get all these sort of things. Is there an in-between there that could occur? And much of the emphasis is on exclusive breastfeeding, and I don't ever want it to be misconstrued that I don't support exclusive breastfeeding. I'm a massive fan of exclusive breastfeeding, and that should always be our priority. But I think those of us that have worked in the field, like all of you have worked in the field, it's not realistic. I think we have to just accept that tragedy, honestly, that exclusive breastfeeding is just not happening among most rural populations, most urban populations too. In the rich world, in the developing world, in the Eastern world, in the Western world, the Northern world, and Southern world, exclusive breastfeeding is an aspirational goal that we are not anywhere near. And in the meantime, babies are suffering and dying from undernutrition because of this. And unless we can massively change that exclusive breastfeeding rates, we're not going to help. A lot of babies are going to die in the meantime. And so we can't just say, get back to breastfeeding and hope that that works. That's going to leave a lot of babies suffering in the meantime. And much of this is due to premature introduction of complementary foods. So in places I've worked in rural Malawi, rural Liberia, rural Laos, the local foods, the porridges, the pala, the sima, these sort of things that people in East Africa are familiar with, are introduced very early on, 2 months, 3 months, 4 months, 5 months. And this, I think, is a big contributor to the wasting that occurs, to the loss of developmental milestones that occurs, because it has displaced exclusive breastfeeding. I would love to get all these babies back on exclusive breastfeeding, but culturally and because of the mother's own health and mother's own need to work, it's not happening. And so they're given complementary foods that are suboptimal for their development, and they're given it at an age that's not optimal. So given some of this background context, right, given that a large number of these infants suffer from wasting, most have already stopped exclusive breastfeeding, and that outpatient therapeutic programs for children above 6 months for both severe and moderate wasting already exist in many settings and are already effective in many settings and are slowly, hopefully, continuing to spread to new contexts and coverage is improving. And given that hospitalization is not often practical, it often requires a large distance for travel, money that the family doesn't have. The mother has to feed herself while she's in the hospital. She has to neglect her other children at home and her own farm and things like that. And given also that many of these infants who are under 6 months maybe have a mother that's ill herself, or maybe has no mother and is being cared for, like this baby in this picture that I met in Malawi, who, you know, the mother is the 12-year-old sister, you know, it has become the mother. So it's not easy for her to take the baby to the hospital. It's obviously not possible for her to resume exclusive breastfeeding. Yeah. The question arose, would it be safe and effective to treat wasted infants under 6 months with therapeutic food products as outpatients, right? So we've often thought we shouldn't do this because it displaces exclusive breastfeeding, but if exclusive breastfeeding already doesn't exist and can't quickly be returned, is this possible? So this was the paper that Marco mentioned that we, you know, just published online, and I don't think it's come out in the journal issue yet, but it's published online now. It's open access, and people want to get access to it, or I can email it out. Where we sort of looked at what happened in real life. It wasn't a study that we designed intentionally ahead of time. It was something we just sort of noticed. So it's a chart review of operational field data, and it conducted in southern Malawi at a network of 20 CMAM clinics that we supported through our research and operational group. And the population we were interested in was these infants under 6 months with uncomplicated CMAM, right? So the child who is septic or hypoglycemic clearly needs to go to the hospital. The criteria we used was weight for height under 3, or edematous malnutrition exists in a fair degree down there. And the caregivers reporting an inability to take the child to the hospital. So in these clinics, our nurses did the sort of traditional pathway, which was see if they could be easily breastfeeding supported or supported of the mother, and if not, told you need to go to the hospital. And the mothers or the aunts or the sisters or whoever's taking care of the child says that's just not possible. We can't go. It's too far. It's too expensive, etc. And so what our nurses were doing was they were, you know, not really behind our backs, but sneakily they were feeding these children. They were giving them RUTF if they were severely malnourished. They were giving them a supplemental food if they were moderately malnourished, depending on what we had in supply or which research study was going on, or sometimes even RUTF. Just following a weight-based dosing that we had been used for children above 6 months. And they would do a test feeding, and they would do, you know, feeding counseling and how to feed these supplementary or therapeutic foods and just feeding them. And, you know, because it's a site where some children were not on the research studies, we still kept track of them in the sense of you go home, this is your weight today, this is your weight 2 weeks from now, et cetera. This is your recovery criteria, the sort of traditional CMAM model. We had this data on these data cards sitting around. So we, you know, looked at that data. And so the first pass, the idea of the study was, okay, well, we could just do a descriptive study of what outcomes were for these children under 6 months. But it would seem useful to have a comparison, right? Because each context is so different, you know, from country to country, from northern Malawi to southern Malawi, of how well the children do, what their baseline demographics are like, how much edema there is, things like that. So we figured out the closest comparison group would be children just above 6 months, right? So if it's considered acceptable to feed children above 6 months with these therapeutic foods and supplementary foods, what about the children below 6 months? So we compared them to children 6 to 9 months old who were enrolled in our research trials at the exact same time, so we had good data collection on them also. So looking at the baseline characteristics of these children, the average age was fairly close to 6 months, right? So we weren't really treating a lot of 1 or 2 month olds, and this probably reflects the fact that they need to pass an appetite test. So they're mostly, you know, around 5 months old, but they're a touch under 6 months. Most of them were still breastfeeding. We didn't collect exclusive breastfeeding information, so that's a definite limitation of our data. But anecdotally or experientially, I would say that somewhere near 0% of them are exclusively breastfeeding. So maybe the number is 10% or 20% or something. But the exclusive breastfeeding rate is extremely low. It is a population in southern Malawi that has a fair bit of edematous malnutrition. We've seen in more recent studies where we've expanded to use MUAC as an enrollment criteria. We would enroll a lot more infants and younger children, and the percentage that would be enrolled by edema would go down. So when you just do weight for height and edema, the percentage of quash is pretty high. When you use MUAC or more recently weight for age as a good marker of a high risk severely malnourished or moderately malnourished infant, this percentage goes down. So that's something to take into context if you try to think about this data in your own settings. And so the total number was about 150 in each group. I'm sorry, 130 in the severely malnourished group and 193 in the moderately malnourished group. This is the exact same table, but with even more detail. It's in the paper. I didn't know. I tried to make those other tables to try to simplify the amount of numbers in your face, but nothing too much different or surprising. So then these children were enrolled and fed in a non-research way, just as an operational way, and we looked at their outcomes. So if we look at these infants under 6 months of old, 130 of them, 75% recovered. If we compare them to an age group just above where it is considered a normal standard practice to feed them ready-to-use therapeutic food, 75% recovered. The duration of therapy was very similar statistically between them. The weight gain was very similar. The failure to recover was very similar. If we break this down further among the under 6 months old into even more fine detail, if you look at the 5 to 6 month old age, we get 76% recovery. The 4 to 5 month age, we get 67%, and the less than 4 months age, 84%. The numbers get very small, so you lose a lot of statistical power. But at least there's no obvious major fall off in any of these sort of basic outcomes, even if you go, you know, a fair bit younger than 6 months. This is again that same table with more details that's in the paper, but I tried to summarize the major findings in that other table. When we look at moderately malnourished children, similar results. When you look at moderately malnourished children under 6 months, we get about an 81% recovery rate. Moderately malnourished 6 to 9 months, an 85% recovery rate. Statistically, these are the same, essentially the same number. Duration of therapy is very similar. The weight gain was actually a little better among the children under 6 months. This probably is a sort of a regression to the mean, if you will, but they started out more, they have more room to grow, so to speak. Failure is similar. And then again, if you look at 5 to 6 months, 4 to 5 months, and under 4 months, the recovery rates are quite similar, with the caveat, of course, that we're getting to fairly small sample sizes with the particularly low rate. I apologize, this is a typo here. These should be MAM children. And again, the same table with more details from the paper that we can talk about if you want to get into more details. So, trying to think about what can we learn about these children? What is the, some differences in risk factors and things like that. So if we compare children under 6 months, the infants under 6 months who did recover with those who did not recover, with, again, relatively small numbers, given that this was sort of operational and wasn't the most common practice. The breastfeeding rate, those who recover have better breastfeeding rates. So that's clearly a protective thing. So once again, we do need to try to encourage getting as close to exclusive breastfeeding as possible. Even if we can increase it a bit, that's quite likely to help. But this was breastfeeding at the time of enrollment. Not surprisingly, children who were more wasted with a lower weight for height Z-score, weight per length Z-score, had a higher risk of not recovering. That's not surprising. Well, those with a lower weight for age Z-score, more underweight at baseline, had a higher risk of not recovering. Those who had a lower MUAC had a higher risk of not recovering. So sort of obvious anthropometric risk factors that I think we're all familiar with. More diarrhea increased your risk of not recovering, just as we often see with children over 6 months. And those who did happen to have a higher positive HIV test rate, the mothers who had more HIV were more likely to not have their children recover. So we didn't collect a whole lot of data about these children, given that it was an operational setting, but no surprising risk factors, I should say, for failure to recover. Same thing with moderate malnutrition. This is again from that book, from that table. The anthropometry didn't seem to be as big of a play. I interpret this as there's just less room to have anthropometric differences when you're looking at moderate malnutrition. You're looking at a narrower range of weight for height in our enrollment criteria, which means likely a narrower range of the other anthropometric variables. Fever and vomiting are risk factors for failing to recover. Not having your biological mother as your primary caregiver is a risk factor. So, if an older sister is taking care of the baby or the father alone, things like that. So, lots of limitations, small sample size, retrospective. It wasn't, a randomized trial. Unknown confounders or biases are obviously always possible with this retrospective cohort. Almost all the subjects were at least 4 months old, in the 4 to 6 month range. So not really going down very low. So when we say under 6 months, I don't, with the caveat that we're not really going down to zero. It's really just a pilot study, a hypothesis generating study to see, is this safe? And I think that many of you will have probably fed children under 6 months with these sort of foods in this sort of model. But maybe, I think we're the first ones to sort of collect the data and put it out there just for the international community to discuss. We did not use MUAC or weight for age, Z-score for screening at the time. No long-term follow-up in terms of relapse or long-term mortality. We just sort of followed them for up to 16 weeks. Some strengths are that we have these controls that I think are actually really helpful to see, is 81% a good number or a bad number? Well, in Southern Malawi, in a well-designed, randomized controlled trial with the Hawthorne effect and good interventions, it's about the same as these children under 6 months. So I think that helps put this into context as to how effective this is. It's operational setting, right? These children didn't get any extra care, didn't get any extra research attention. So hopefully that means it's a little, applicable beyond this paper. And I think a big strength from a programmatic standpoint is it leverages the currently available protocols. It doesn't require developing a whole lot of new protocols. You do the same sort of test feeding, you do the same sort of counseling, you do the same sort of staff, you use the same sort of staff in the same settings. It doesn't require a whole new layer of interventions and financing and all those sort of things. So, our conclusion with this that is, at least in this operational setting, children under 6 months with wasting had similar outcomes to children 6 to 9 months old. And therefore, it may be possible to effectively treat these children using the existing CMAM care models in terms of the staff and the therapeutic food commodities. Providing RUTF or these supplementary foods is not going to be the thing that disrupts inclusive breastfeeding. That's already happened. We should support inclusive breastfeeding or increasing breastfeeding when these children are wasted, but we shouldn't just wait for that to help, because every day that goes by, these children are losing, cognitive capacity and long-term development. And what I would love to talk to this group about is that we should do a prospective randomized trial that would have a lot of logistical challenges, because you're talking about an outpatient versus an inpatient admission, or an outpatient with food versus an outpatient with counseling and maternal support. as the primary intervention. And so there's, you know, how do you randomize two women sitting next to each other, one to the other, when they see the other one is getting something, right? So it'd be a very challenging randomized trial. It would be unblinded for everyone involved, essentially. But I think that obviously is the strength of the strongest form of data. And I think if something like this, and I'm not saying we're at this point, but if something like this is expanded, you could really help a lot of infants. There's a lot of infants that are coming to sites where CMAM programs exist and might benefit. And I would love to see less infants suffer needlessly, and it could also decrease the burden on inpatient settings if it's just as good. I mean, I think 80 to 85% recovery in an inpatient setting for an under 6 months old child would be wonderful. In the places I work, that'd be better than the current outcome. So it would also help decrease the burden on those inpatient settings and the cost and burden on the health system and burden on the families. So that's all I have to say. I'm very much looking forward to discussing this with everyone.